45. The appendix. What vessel provides blood supply to the appendix?
Appendiceal artery, branch of the ileocholic artery.
Name the mesentery of the appendix.
Mesoappendix contains the appendiceal artery.
How can the appendix be located if the cecum has been identified?
Follow the Taenia coli down to the appendix. The Taeniae converge on the appendix.
Appendicitis. What is it?
Inflammation of the appendix caused by obstruction of the appendiceal lumen, producing a closed loop with resultant inflammation that can lead to necrosis and perforation.
What are the causes?
Lymphoid hyperplasia, Finkeleth, also known as appendicolith. Rarely, parasite, foreign body, tumor, for example, carcinoid.
What is the lifetime incidence of acute appendicitis in the United States?
Approximately 7%.
What is the most common cause of emergent abdominal surgery in the United States?
Acute appendicitis.
How does appendicitis classically present?
Classic chronologic order. 1. Periumbilical pain, intermittent and crampy. 2. Nausea, vomiting. 3. Anorexia. 4. Pain migrates to right lower quadrant, constant and intense pain, usually in less than 24 hours.
Why does periumbilical pain occur?
Referred pain.
Why does right lower quadrant pain occur?
Peritoneal irritation.
What are the signs, symptoms?
Signs of peritoneal irritation may be present: guarding, muscle spasm, rebound tenderness, obturator and psoas signs, low-grade fever, high-grade if perforation occurs, right lower quadrant hyperesthesia.
Define the following terms. Obturator sign.
Pain upon internal rotation of the leg with the hip and knee flexed, seen in patients with pelvic appendicitis.
Psoas sign.
Pain elicited by extending the hip with the knee in full extension or by flexing the hip against resistance, seen classically with retrocecal appendicitis.
Rovsing's sign.
Palpation or rebound pressure of the left lower quadrant results in pain in the right lower quadrant, seen in appendicitis.
Valentino's sign.
Right lower quadrant pain, peritonitis, from succus draining down to the right lower quadrant from a perforated gastric or duodenal ulcer.
McBurney's point.
Point 1/3 from the anterior superior iliac spine to the umbilicus, often the point of maximal tenderness.
What is the differential diagnosis for everyone?
Meckel's diverticulum, Crohn's disease, perforated ulcer, pancreatitis, mesenteric lymphadenitis, constipation, gastroenteritis, intussusception, volvulus, tumors, UTI, for example cystitis, pyelonephritis, Torst epiploicy, cholecystitis, cecal tumor, diverticulitis, floppy sigmoid.
What is the differential diagnosis for females?
Ovarian cyst, ovarian torsion, tubo-ovarian abscess, Mittelschmerz, PID, pelvic inflammatory disease, ectopic pregnancy, ruptured pregnancy.
What lab tests should be performed?
CBC, increased WBC, greater than 10,000 per millimeters cubed in greater than 90% of cases, most often with a left shift. Urinalysis to evaluate for pyelonephritis or renal calculus.
Can you have an abnormal urinalysis with appendicitis?
Yes, mild hematuria and pyuria are common in appendicitis with pelvic inflammation resulting in inflammation of the ureter.
What additional tests can be performed if the diagnosis is not clear?
Spiral CT, ultrasound. May see a large, non-compressible appendix or fecalith. Abdominal X-ray.
In acute appendicitis, what classically precedes vomiting?
Pain. In gastroenteritis, the pain classically follows vomiting.
Does a positive urinalysis rule out appendicitis?
No. Ureteral inflammation resulting from the periappendiceal inflammation can cause abnormal urinalysis.
What radiographic studies are often performed?
Chest x-ray to rule out right middle lobe or right lower lobe pneumonia or free air. Abdominal x-ray. Abdominal films are usually nonspecific, but calcified fecalith present in about 5% of cases.
What are the radiographic signs of appendicitis on an abdominal x-ray?
Fecalith, sentinel loops, scoliosis away from the right because of pain, mass effect, abscess, loss of psoas shadow, loss of preperitoneal fat stripe, and very rarely, a small amount of free air if perforated.
With acute appendicitis, in what percentage of cases will a radiopaque fecalith be on abdominal x-ray?
Only approximately 5% of the time.
What are the CT findings with acute appendicitis?
Periappendiceal fat stranding, appendiceal diameter greater than 6 millimeters, periappendiceal fluid, fecalith.
What are the preoperative medications preparation?
1. Rehydration with IV fluids, lactated ringers. 2. Preoperative antibiotics with anaerobic coverage. Appendix is considered part of the colon.
What is a lap appy?
Laparoscopic appendectomy, used in most cases in women, can see adnexa, or if patient has a need to quickly return to physical activity or is obese.
What is the treatment for non-perforated acute appendicitis?
Non-perforated, prompt appendectomy prevents perforation, 24 hours of antibiotics, discharge home usually on postoperative day 1.
What is the treatment for perforated acute appendicitis?
Perforated, IV fluid resuscitation and prompt appendectomy. All pus is drained with postoperative antibiotics continued for 3 to 7 days. Wound is left open in most cases of perforation after closing the fascia. Heals by secondary intention or delayed primary closure.
How is an appendiceal abscess that is diagnosed preoperatively treated?
Usually by percutaneous drainage of the abscess, antibiotic administration, and elective appendectomy approximately 6 weeks later, also known as interval appendectomy.
If a normal appendix is found upon exploration, should you take out the normal appendix?
Yes.
How long after removal of a non-ruptured appendix should antibiotics continue post-operatively?
For 24 hours.
Which antibiotic is used for non-perforated appendicitis?
Anaerobic coverage. Cefoxitin, cefotetin, Unison, Cipro, Flagyl.
What antibiotic is used for a perforated appendix?
Usually triple antibiotics. For example, ampicillin, Cipro, clindamycin, or a broad-spectrum penicillin such as Zosyn.
How long do you give antibiotics for perforated appendicitis?
Until a patient has a normal WBC count and is afebrile, ambulating, and eating a regular diet, usually 3 to 7 days.
What is the risk of perforation?
Approximately 25% by 24 hours from onset of symptoms, approximately 50% by 36 hours, and approximately 75% by 48 hours.
What is the most common general surgical abdominal emergency in pregnancy?
Appendicitis, about 1 in 1,750. Appendix may be in the right upper quadrant because of the enlarged uterus.
What are the possible complications of appendicitis?
Pelvic abscess, liver abscess, free perforation, and portal pylothrombophlebitis, which is very rare.
What percentage of the population has a retrocecal retroperitoneal appendix?
Approximately 15%.
What percentage of negative appendectomies is acceptable?
Up to 20%. Taking out some normal appendixes is better than missing a case of acute appendicitis that eventually ruptures.
Who is at risk of dying from acute appendicitis?
Very old and very young patients.
What bacteria are associated with mesenteric adenitis that can closely mimic acute appendicitis?
Yersinia enterolytica.
What is an incidental appendectomy?
Removal of normal appendix during abdominal operation for different procedure.
What are complications of an appendectomy?
SBO, enterocutaneous fistula, wound infection, infertility with perforation in women, increased incidence of right inguinal hernia, stump abscess.
What is the most common postoperative complication?
Wound infection.
Classic intraoperative questions. What is the difference between a McBurney's incision and a Rocky Davis incision?
McBurney's is angled down, follows external oblique fibers, and Rocky Davis is straight across, transverse.
What are the layers of the abdominal wall during a McBurney's incision?
1. Skin. 2. Subcutaneous fat. 3. Scarpa's fascia. 4. External oblique. 5. Internal oblique. 6. Transversus muscle. 7. Transversalis fascia. 8. Preperitoneal fat. 9. Peritoneum.
What are the steps in laparoscopic appendectomy, lap-appy?
1. Identify the appendix. 2. Staple the mesoappendix, or coagulate. 3. Staple and transect the appendix at the base, or use endoloop and cut between. 4. Remove the appendix from the abdomen. 5. Irrigate and aspirate until clear.
Do you routinely get peritoneal cultures for acute appendicitis, non-perforated?
No.
How can you find the appendix after identifying the cecum?
Follow the tinea down to where they converge on the appendix.
Which way should your finger sweep trying to find the appendix?
Lateral to medial along the lateral peritoneum. This way you will not tear the mesoappendix that lies medially.
How do you get to a retrocecal and retroperitoneal appendix?
Divide the lateral peritoneal attachments of the cecum.
Why use electrocautery on the exposed mucosa on the appendiceal stump?
To kill the mucosal cells so they do not form a mucocele.
If you find Crohn's disease in the terminal ileum, will you remove the appendix?
Yes, if the cecal appendiceal base is not involved.
If the appendix is normal, what do you inspect intraoperatively?
Terminal ileum, Meckel's diverticulum, Crohn's disease, intussusception, gynecologic, cysts, torsion, etc. Groin, hernia, rectus sheath hematoma, adenopathy, adenitis.
Who first discovered treatment for acute appendicitis?
Reginald Fitz.
Who performed the first appendectomy?
Harry Hancock in 1848. McBurney popularized the procedure in the 1880s.
Who performed the first lap-appy?
Dr. Sem, a gynecologist, in 1983.
Appendiceal tumors. What is the most common appendiceal tumor?
Carcinoid tumor.
What is the treatment of appendiceal carcinoid less than 1.5 centimeters?
Appendectomy, if not through the bowel wall.
What is the treatment of appendiceal carcinoid larger than 1.5 centimeters?
Right hemicolectomy.
What percentage of appendiceal carcinoids are malignant?
Less than 5%.
What are the differential diagnoses of appendiceal tumor?
Carcinoid, adenocarcinoma, malignant mucoid adenocarcinoma.
What type of appendiceal tumor can cause the dreaded pseudomyxoma peritoni if the appendix ruptures?
Malignant mucoid adenocarcinoma.
What is Mittelschmerz?
Pelvic pain caused by ovulation.
Should one remove the normal appendix with Crohn's disease found intraoperatively?
Yes, unless the base of the appendix is involved with Crohn's disease, The normal appendix should be removed to avoid diagnostic confusion with appendicitis in the future.